All right, Assalamu alaikum, everybody. So we'll continue actually with the last lecture of this series. That's going to be the tumors of the genitourinary block. And we have already gone over the prostate, and we are going to continue today with kidneys, ureter, and our pelvis and bladder. So starting with tumors of the kidney, starting with benign tumors, papillary adenoma. This is most likely going to be an incidental findings. Now we have powerful imaging, studies that could be used to, usually screen other things, but in the process of doing so, you will pick, findings that were silent before. Usually the tumor is silent, does not really present with any kind of symptom because it's a small tumor. By definition, it should be less than 1 centimeter. Anything above 1 centimeter, 1 to 3 centimeter, that's what you put actually in the suspicious category. Anything above 3 centimeter is going to be most likely carcinoma, believe it or not. So the size of the tumor is very important. Now, so it's discovered, incidentally on an imaging study done for something else. And then that's, unfortunately, that's going to open a Pandora box for you because you have to, you have to biopsy the tumor. You have to find out if it's a benign tumor, if it's malignant tumor. You may actually use all your imaging criteria, the capsule, the intensity of, of the staining of the imaging. You may use a lot of criteria, but the golden, rule is going to come to you from histopathology. So you need to biopsy the tumor, and the biopsy in most cases is going to be, is going to be benign when the tumor is actually less than 1 centimeter. So increased size is going to be something that you need to deal with, and that's going to be even more reason for you to biopsy the tumor. Now, in terms of histopathology, it's going to be actually, histologically, it's going to be papillary, but could also be clear cell type. Now, again, that is going to actually mirror what you find with, with renal cell carcinoma, because there are subtypes of renal cell carcinoma that are clear cells, and there are another subtype that is actually papillary, shaped. Where does it come from? It is coming from the cortex. You see, most of the tumors are going to be actually coming from the cortex. Now, angiomyolipoma is a form of hamartoma. What's a hamartoma? Normal growth. Actually, I would say normal, tissues that belong to the location, but they are haphazardly arranged, right? They are not arranged the normal way. So in this case, sure, you do see smooth muscle, you do see fat cells, and also blood vessels in the kidney, but you will not see it in the form of a tumor like you see here with angiomyolipoma. Now, in terms of, what is it exactly made up of, I mentioned it to you, and you can guess that from the name itself. So angio, so that's a blood vessels, myo, that's muscles, right? And lipoma is fat tissue. So it's pretty straightforward when it comes to pathology. You cannot be more flat-footed than this. Now, in terms of actually its association, it's a benign tumor overall. Association, it may be associated with different kind of, syndromes, including the tuberous sclerosis that is associated with CNS tumors that, may present with epilepsy, also, skin lesions. It may actually be bilateral, sometimes multifocal kind of presentation. Now, if you want to take a look at that, exactly what the, what the description says. So you will see the blood vessels right here. So you would say probably that's a bad choice. Yes, was worst choice. Go back here. So blood vessels right here, as you can see here, this is one. Fat right here, and also smooth muscle that is, part of this presentation. It's a poorly defined tumor. So in terms of actually, having a capsule, usually lack a capsule, but not because it's malignant, just because it's simply a hamartoma. Now, oncocytoma, now we're getting to the real deal. Oncocytoma is a tumor that may actually gain very large size. It actually has a very peculiar, finding on gross pathology, and that is, and also on imaging, that is the presence of a stellate scar. So presence of a central stellate scar, a scar that has the shape of a star actually in the center of this tumor, arising from the intercalated cells of the collecting ducts, again from the cortex, and associated with certain chromosomal abnormalities, loss of chromosomes 1, 14, and Y. The color of it, is a mahogany color. You cannot really miss it if you have seen it once, especially when it is, when it has this central stellate scar. The cells itself are monomorphic, meaning having all the same shape, round, small, and have ample amount of eosinophilic cytoplasm. The cytoplasm of these tumor cells are granular, and that cytoplasm actually on electron microscopy will show in the form of mitochondria. And that is an important actually finding in those tumors, because one of the questions that will be asked, what kind of cytoplasm, why the cytoplasm is so granular and so ample in those types of tumors. So you will see the oncocytomas having this stellate scar, this central region, where you see this, pinkish, collagen tissue is where the scar is. And the cells, as you can see, are all monomorphic. So all the same, almost the same shape, very monomorphic nuclei and a lot of cytoplasm. If you take a section of this tumor, a fresh section, and send it to the electron microscopic studies, it will show actually these distended cisterns, so many of them. These are actually the mitochondria. Again, benign tumors, that that may actually go into the differential diagnosis with some subtypes of renal cell carcinomas. Now we're coming to the real deal. The renal cell carcinoma. Renal cell carcinoma has different names, so make sure that you know the different names, because this is one of the way you may be tricked actually. So hypernephroma is another name, Grawitz tumor, and renal adenocarcinoma. All of them refer to the same actually entity, which is the renal cell carcinoma. Old age is going to be there. And it's about 80 to 85% of primary renal malignancies, again, arising actually from the cortex. So another cortical tumor may arise in any pole of the kidney, in terms of size, ranging in size from 3, if you recall, the number, the cutoff point of malignancy or almost certain malignancy with benign tumor, 3 to around 15. Some of them are really huge. And it has this very, distinctive, golden sand texture to it. When you cut it, the central part of it is so necrotic, but necrotic in the shape of this golden sand, really. I have done so many of them when I was training, and I cannot forget actually how it looks. In terms of predisposing factors, there are a long list of things that may expose the kidney to the transformation. As you know, this is actually where everything goes out. So whatever you put in, it's eventually going through this route, similar to the GI. So smoking is there, dialysis associated cystic disease. There is a special form of renal adenocarcinoma that is associated with dialysis. Something to keep in mind, cystic form of actually renal adenocarcinoma. Tuberous sclerosis also may be there. Obesity is there. Exposure to industrial chemicals, one of the tumors that are associated with certain industries, in this case, heavy metal industry. We will see that, the urothelial carcinomas are associated with the leather industry as a result of the exposure to aniline dyes. This one is more of the heavy, metals. And the autosomal dominant polycystic renal disease that you guys have studied earlier in this block. Now, knowing actually what, the morphology will help. So the major, two morphology morphologies that you will see with renal cell carcinomas, are the clear cell type and also the papillary type. Now, there are others, but the ones that you need to concern yourself about for medical school are these two types. Now, not only that, but it was found, luckily, that these two morphologies are associated with certain genetic findings. So, with the hereditary clear cell carcinomas, it was found that it is associated with a mutation of the von Hippel-Lindau gene. And if you guys recall the VHL gene from the POD, this is the gene that actually is a form of a tumor suppressor gene, and it does its effect by actually suppressing the neoangiogenesis, right? So, so what happened actually, the tumor, has a mutation in this, or those cells have mutation in this, and as a result of that, neoangiogenesis may happen, freely. The papillary cancer, on the other hand, has mutation in the MET proto-oncogene. And you know what the proto-oncogenes are, right? So proto-oncogene, these are genes are present in all, normal cells. Okay, what do they do in normal cells? Do you guys know? They regulate cell growth. Exactly, very good. So they regulate cell growth, and if they become amplified, then the proto-oncogene will turn into an oncogene. That's actually when it becomes that's when it becomes, that's when it will render the cell, transformed or neoplastic. So arising again from the cortex, and as a result of that, this is where you mostly see it, especially when it's small. Now, when it becomes large, it's going to actually go out of the cortex and to other parts of the kidney. So you will see it in the medulla, you will see it in, taking half of the kidney sometimes. And so it may be arising from, anywhere, but the most common actually is going to be the upper palm. And what else? Now it has also this peculiar, tendency to involve the renal vein. And we have studied that actually, when we talked about testicular pathologies, when there is a sudden, appearance of varicocele, right? So that's actually most likely going to be accompanied by the presence of renal cell carcinoma on that side. And we have talked about why, right? Because that is going to increase the water, column, what do you call it, pressure, if you will, on the pampiniform plexus in the testes. Here is an example of renal cell carcinoma that is arising actually from the central region of the kidney. It's, as you can see, it's really huge. Now here's another one. That one is not cut. This one is cut. This is arising from the lower palm. And you can see, this very distinctive, yellowish color to it. In addition to this, you see that, it does have a, hemorrhage, that are spread all over this tumor. Areas of necrosis, as you can see more, here towards the sides. And you can see that, there is what looks like, a capsule. Of course, even though it does have a capsule, it has gone out of the capsule and has invaded the nearby structures. Here's a microscopic section of a clear cell renal cell carcinoma. You can see actually this very, distinctive pattern. And also, in addition to this, you see this kind of arborizing blood vessels. It's a very profusely, supplied tumor. What do you think is the reason you have this clear cytoplasm? Lipid, exactly. And is that the lipid that you're looking at?
No.
No. So what is it?
Washed out.
Washed out. Very good. Excellent. Wow, another pathologist in the making. So what happened actually when you process the tissue that has lipid the routine way, all right, so lipid will wash out, exactly how he puts it. Now, in order for you to be able to appreciate the lipid, what kind of stain will you do? Oil red O, very good. Oil red O stain that is going, and there's a lot. Sudan black, Sudan B black may also pick it up, but oil red O is the most commonly used. Here's actually another, the most probably the second most common, or another most common, renal cell carcinoma with this very peculiar papillary structures. So what's a papilla for you? What does a papilla mean? Finger-like projections. Okay, so how about that? Does any finger-like projection, what do you call it, qualify to be a papilla? No. So what's the most important part of a papillary structure? The central vascular core. Excellent. So the this is what really the papilla should be, the definition of papilla. Central vascular core, right? That is surrounded with epithelium from all sides. So sure, some of the structures look like papilla, but that's what you call pseudo-papillary structure, okay? And, that's not the case here. It is a true papilla because you can see actually the central core in each one of those, segments. Now, have you heard about other, probably not so far. You have taken what? CVP and heme and MSI. So the papilla that you're gonna see a lot of other papillary tumors. And papillary tumors, for example, you're going to be seeing that also in the thyroid, papillary carcinoma of the thyroid. Also, you're going to be seeing that with actually the ovary. So papillary, serous papillary ovarian adenocarcinoma. You will see that those tumors actually share certain morphological features to them. By and large, they will have what you call nuclear morphologic, very distinctive nuclear morphologic abnormalities. In addition to the fact you have these kind of dark structures. What are they? Samoma bodies. Good. Samoma bodies. So this is you're going to be seeing in this papillary tumor and in other papillary tumors as well. Now, I shied away from actually going into a discussion of nuclear, changes because the nuclear changes are not in all papillary tumors, but for example, in papillary adenocarcinoma of the thyroid, it is very peculiar, type of, nuclear abnormalities. You will have what's known as nuclear, pseudonuclear inclusions. You will have also nuclear, you will have nuclear membrane irregularities as well. Yes. Which one? I'm sorry. Right, the other one, the MEC, the MET. I'm sorry, MET. I apologize. MET gene. All right. All right. So how does it present? In this case, actually, remember, it's a tumor arising in the kidney. Okay. So there will be blood in the urine. In this case, actually, it may actually come in the form of macroscopic hematuria, but that's usually rare, and when it happens, it will happen very transiently, meaning it will not always be there, okay? But what's going to be persistent and always there is going to be the microscopic hematuria. So if you do urinalysis for a patient with renal cell carcinoma pretty much all the time, you will see that there is RBCs in the blood, but it will not be in the form of a frank hematuria. Now, what you will find actually shared with urothelial cancer is both of them are painless, okay? So painless microscopic hematuria, possibly, gross hematuria that you see in RCC, and painless, gross hematuria, which is more likely to be seen with urothelial cancer. Both of them are painless. Painless, pain-free is always actually pretty much everywhere you go is, a sign of actually more neoplastic, process than any inflammatory process. All right, so pain is less likely to be the presenting symptom. When it is there, that tells you actually that the tumor has gone out of the capsule and has invaded nearby tissue. So it's pretty bad, omen to have, pain in the scenario of renal cell carcinoma. Now, some of those tumors, remember, actually, this is the site where, the EPO, the erythropoietin, is getting produced. What cells produce the erythropoietin? What do you call it? Peritubular? Very nice. I call it EPO cells, actually. How about that? Just to be like straightforward, just going back to my specialty of pathology, right? And, so some of these cells actually retain the ability to do the same. And as a result of that, about 5%, 5 to 10% of cases of RCC continue to produce EPO, in large amounts. in this case, without actually having to sense any kind of, decrease in the PaO2 that is, coming with the blood. So it's happening, what's called ectopic production, excessive production. So it's in the form of paraneoplastic syndrome. There are other paraneoplastic syndromes. It's a pretty, active hormonal tumor or hormonally active tumor. Other paraneoplastic syndromes, in addition to polycythemia that could be seen, include Cushing's, hypercalcemia, and hypertension. What other tumor is also known to be a very probably the most hormonally active tumor? Small cell carcinoma of the lung, absolutely. All right, so triad, remember that. Painless hematuria, palpable abdominal mass, and flank pain is characteristic. So what will happen? Let me ask you this. We did not even get to it, but let's ask this. If you have someone who's presenting to you with gross hematuria, okay, or microscopic hematuria, but in the absence of an abdominal pain, an abdominal mass, and flank pain, what will that be? Transitional cell, exactly. So if it's not that, right, the two of them is actually using the same, exit pathway, if you think about it. So if it's not the first one, it has to be the second. In this case, it will be the urothelium. One very important feature I forgot to mention to you about renal cell carcinoma is that most of the time it is multifocal. Why do you think it is multifocal? What do you call this actually process? Field effect. Excellent. Field effect. Where else do you see field effect? GI, the GI route as well. And why is that the case? What does field effect means?
All of the epithelium.
All the what? All the epithelium is what?
They have mutation.
Not that really. I more like, again, you would go back to environmental kind of. So epigenetic really is going to be the rule of the day for most of them. So what happens? What do I mean by that? So if someone is go ahead. No, it's not about spread. It's not about spread like you see in prostatic adenocarcinoma. Sure, a tumor could spread. One tumor, as you would see in the GI block, that could spread this way, exactly what you're saying, is known actually as signet ring cell carcinoma of the stomach. I had one case like this. The tumor was spread from the upper esophagus all the way to the rectum, believe it or not. A very crazy finding, and probably one of the rare ways of spread, but it can spread that way because it spreads in the submucosa. Okay, so you look at the mucosa looks fine, really. There is no kind of dysplastic changes in the mucosa, but the tumor is spreading these signet rings, which is highly aggressive aggressive cells are going to spread in the submucosa. But what's happening here is that the same actually carcinogen that the person is ingesting in the mouth is having its effects also in the esophagus, right? It's having its effects on the stomach, having its effect on the small intestine and the large intestine, right? And of course the blood, but this is actually direct effect. So whatever you put in, so the airways, absolutely, this is why someone who smokes will have all types of cancers, right? Oral cancer, laryngeal cancer, pharyngeal cancers, bronchial cancer, bronchogenic carcinomas, right? The same exact thing with the GI, and the same exact thing actually with the renal tumors. So you will see a lot of multifocality actually in those type of tumors, and the renal cell carcinoma does not really negate this rule. You will see that as well here, because again, it is going through the kidney and it's affecting everywhere from the kidney all the way to the urethra. All right, so metastasis, the cannonball, you guys know about that, right? This is something that, the cannonball, or if you are more like, American inclined, what would you call it? Shotgun, right? So, like the Arnold Schwarzenegger type of, sending someone to the other life. Okay, so this is exactly what you find here. And remember the renal vein actually involvement of this tumor. This makes actually for a nice question on any exam, if you ask me. All right, transitional cell carcinoma of the renal pelvis. So we are still in the kidney, but now we are in the renal pelvis. In this case, you will see that 5 to 10% of renal carcinomas are actually those of the urothelial subtype. And they are, they are more likely to produce, prominent hematuria, prominent gross, painless hematuria. They invade early because of the thin wall of the pelvis and into nearby structures in the kidney. So at one point in time, you may ask yourself, what do I have? Is it actually a renal cell carcinoma that has invaded the pelvis, or pelvic, carcinomas, pelvic urothelial carcinoma that has invaded, the rest of the kidney? Of course, microscopically is going to nail it for you, because each one of them have its own peculiar, morphology. And you can see here the multiplicity that you see here in this tumor as well. Okay. Similar to what you see with renal cell carcinoma, similar to what you're going to be seeing is in urinary bladder carcinomas as well. So you take a section of this. This is what you are going to be finding, if you are dealing with a tumor of the transitional epithelium, regardless of where it is. Is it in the pelvis, or in the ureter, or in the urinary bladder? All of them are going to be actually, appearing like this. So the normal thickness of the urothelium is about 2 to 3, layer thick. And as you can see here, there is a lot more than that, and also, you apply all the things that you have learned before in terms of, pathology. So you will see that there is no maturation, there is high NC ratio, not very high NC ratio. The cells look very much, like each other, but there are cells of them that look a little bit, more dysplastic than the others. You see that there are a lot of mitosis in the most upper layers of this urothelium, as you can see here, instead of actually being limited to the basal layers of the urothelium. All of these are mitosis. Okay. And you can see what it is. It is way up here, as opposed to being actually near the basement membrane. All right, so it's a pretty, it's definitely a urothelial cancer, but not the worst type of urothelial cancer, as we will see in the next few slides. There is, what you call a low grade and a high grade. It used to be 3 grades, grade 1, 2, and 3. Now they have divided it into 2 grades, the low grade urothelial cancer. This one actually is going to be mostly like a low grade urothelial carcinomas, as opposed to the high grade that we will see in the next slides. All right, tumor-like lesions of the lower urinary tract of the male genital system, starting with that of the bladder. So the majority of the tumors are going to be of the epithelial type. So they will arise from the urothelium. Now remember, you have still the urinary bladder wall that has all kinds of cells. Any kind of cell may actually give rise to any kind of tumor. So you will see mesenchymal tumors, you see neurogenic tumors, you see the whole 9 yards actually that may arise from the urinary bladder wall, but the majority of the tumors arising are going to arise from the urothelium. Now, this is what used to be called transitional cell carcinoma. So if you open a book, older book, and you see this nomenclature, that's the same as urothelium. Most of the tumors are of the urothelial subtype, 90% of that subtype, which is good because the other subtypes, such as adenocarcinoma and small cell carcinomas of the urinary bladder, are far more aggressive than the urothelial cancers. So what are the risk factors for urothelial carcinomas? Cigarette smoking is going to be there, similar to what you have seen in the renal cell carcinomas. And also it's a tumor that have some industrial kind of linkage, including, patients who have worked in factories, leather factories, and were exposed to aniline dyes, in the arylamines, for, an extended period of time. There will be an incubation period, about 15 to 40 years, before they actually are going to develop these types of tumors. Schistosomal infections that may actually give rise to chronic cystitis, that may, again, result in the development of, in this case, squamous cell carcinomas, because they will be associated with squamous metaplasia over a long period of time, and that may actually become dysplastic at one point in time. Now, the rest of the tumors that will arise from schistosomal infections, from bilharzial infections, will be urothelial cancers. Now, there's also association with certain analgesics, long-term use of analgesics, and also the heavy use of cyclophosphamide. And we talked about this before, because it's going to predispose to hemorrhagic cystitis. Unfortunately, the patient will have to continue to receive this cytotoxic therapy for his other tumors. In the long run, this may go on to develop into urothelial cancers. Now, radiation and the development of carcinomas, but most likely sarcomas will come out of radiation exposure. But it is there also as a risk factor for epithelial tumors. Now, here is actually what you're going to be finding, in a urinary bladder that has, urothelial cancers. You can see actually that there are multifocal regions that are affected with this process. Again, the fact that, it is the field effect affecting the whole urinary bladder, epithelium, the urothelium, resulting in this multiple, excrescent, type of projections into the lumen. Which tumor do you worry about? The tumor that is bulky and that is projecting into the lumen, or the tumors that dig down? The one that digs down, and the one that dig down actually going to be, some of those may actually dig down for sure, even though you see them that they are fluffy and into the lumen, some of them may have actually a component that is, going down, digging down into the urinary bladder wall. And, as a result of that, wherever it reaches, it's going to increase the stage of the tumor. Now, the ones that you would worry about the most is going to be the carcinoma in situ, because by definition, the carcinoma in situ is going to be a high-grade tumor. And this tumor is not there really to grow, outwardly or intraluminally, if you will. It's going to dig deep. It's going to dig deeper to become an invasive cancer, as you have seen before, actually, especially in POD. And when it does that, that's actually going to be far more detrimental to the staging of the tumor than a papillary tumor that is projecting intraluminally. And you can see that, there are a lot of examples of this field effect. You take a section of this and the right off the bat that this is a high-grade tumor. What do you think? Why do you think this tumor was labeled as high-grade? Differentiation. What do you mean by differentiation? Well, does that look to you like it's well differentiated? Okay. So what kind of cells actually are you looking at now? Anaplastic cells. Which cells are anaplastic cells? The dark ones. Which one? This ones? Okay, very good. So these ugly cells, right? Let's use, some highly used pathologic jargon, right? Oh, very ugly cells, right? You see like 10 pathologists sitting and, discussing, all of them usually above 90 years of age, because, it's a specialty that you don't really use, leave your desk away from, and, incredible experiences. Really, if for any country that would like to upgrade the medical, establishment, there should be so much emphasis on pathology. Unfortunately, in the Middle East, you don't see that. Pathology is still really a support service that is on the periphery of medicine. Whereas in the US, believe it or not, they don't do anything without consultation of the pathologist. I don't say that, as because it's my specialty, no, but because it's really real. You see, that these are the brains really behind medicine, and this is where most of even the research comes out, of medicine. But it's true, most of them, I have, all my teachers in the US were very old, 85 and above. So it was always, and they will always sit with each other, and you have to listen to really how they say. Most of them were New Yorkers, and I started to even love the Brooklyn accent after a while, and they will, do you see these ugly cells? They will start to talk to each other about that, with so much, and it's absolutely true. You can't call it anything else except ugly, really. Very ugly cells. And these ugly cells right here are going to take the tumor a notch up. So you're going to be calling it really an anaplastic cancer or a very high-grade cancer. Is there any other feature that will tell you? So just one point actually before going there, you will see that, all of these are tumor cells, right? So these are what you call the garden variety, your average, dysplastic cell. Those actually takes it definitely a tier up or a couple of tiers up, right? So they are much larger, much more irregular, pretty much no cytoplasm whatsoever. And they are, if I ask you, will they actually be very resistant cells? Like, for example, if you do something known in pathology as a touch prep, and you take, a piece of the tumor and you put it between two slides and squish, the piece between the two slides, that is going to create a cytology prep for you. You look under the microscope, what will happen to those cells that have a lot of chromatin? They will crush together. They are gonna crush. Have you heard the word crush artifact? When you have discussed the small cell carcinomas of the lung, believe it or not, one of the microscopic feature of a small cell carcinoma of the lungs, if you guys recall, is the crush artifact. Of course, there's the molding, where you see that the cells will fit each other like a jigsaw puzzle, but because they are so heavily, rich with chromatin, such large actually nuclei, that when you do something like a touch prep, they will crush. See, these cells actually will definitely crush as well, because they are so rich with the chromatin. Now, what else actually in this section will tell you that this is a high-grade cancer? It's right there staring you in the face.
Necrosis?
Necrosis. Who said necrosis? Excellent. Very good. So necrosis. Why is necrosis like a criteria or like a mark of high-grade tumors? Exactly. So the tumors have actually grown so far. They have outstripped many areas of the tumor from blood supply. Those areas are going to die in the form of necrosis. That's exactly what you have here. So two features in this section that will tell you are dealing with a high-grade tumor. Pretty important to remember, the necrosis and also the high-grade cancer cells, or if you will, anaplastic cells. Okay, what about actually this tumor? What do you think you're going to be calling this tumor? Low grade or high grade? First, it's papillary, right? You agree that? Papillary, high grade tumor. Is high grade tumor? High grade tumor, you say? Absolutely. Why?
High NC ratio.
High NC ratio, absolutely. So, this is a trick actually in pathology. You have to learn it on the scope, really. When you say high grade cancer, for the novice, for the newcomer, he will think that the tumor cell should be really large, right? In reality, a high-grade cell is a smaller cell than even sometimes, a benign cell. Why is that the case? Because the cell has shed most of its cytoplasm. What has gone in size is its nucleus. And that's exactly what you find here. Look at the nuclear size here. And look how much cytoplasm has been shed out. There's very little cytoplasm. So what happened to the NC ratio in this case? It's going to be very high, right? So that's exactly what you find in high-grade cells. So this is a high-grade urothelial carcinomas. All right, so there are other tumors, SCC. Sometimes you see a mix of tumors, so you see urothelial and SCC. If you see SCC, you don't call it a mixed urothelial carcinomas, because SCC is considered to be, again, far less significant in terms of, its clinical addition. But if you find adenocarcinoma, God forbid, that's going to be very detrimental to the tumor, because it will take definitely the prognosis of the patient and make it worse. So a worse prognosis with adenocarcinoma, also with, small cell carcinomas of the urinary bladder. Here is actually some of the risk factors of adenocarcinoma of the urinary bladder that we have gone, over before. Extrophy, if you guys recall that, if you don't see correction of the abdominal wall and also of the urinary bladder wall, that in time, pretty quick, that may actually open the door for intestinal metaplasia and development of adenocarcinoma. Patent urachus that we have talked about as well, and also urachal cyst that we have talked about it. Urachal cyst, for a couple of reasons, is going to be the place for the development of adenocarcinoma. One of them is going to be the fact that it may still have some communication with the urinary bladder. So the urine may actually find its way to the urachal cyst and cause intestinal metaplasia. This is one. Two, actually, it may be the site where, you know, a villus adenoma may reside. It is the third most common site where villus adenomas could be found in the urogenital tract. So villus adenomas, as I mentioned to you, and as you will see even more details in the GI blog, a blog that I'm sure all of you are looking forward to actually going through. Urinary, now there are mesenchymal tumor, as I mentioned to you, any cell may actually give rise to this. That's going to be far worse than anything that you have seen so far. So leiomyosarcomas, you know, are there. You know, rhabdomyosarcomas are there as well. You know, some neurogenic tumors that may arise from neural cells within the urinary bladder wall. Okay, clinical course, painless hematuria. That's the gross. That's most likely actually going to be found with, you know, urothelial cancer than with renal cell carcinomas. So if you want to compare the two, you're going to be more likely to find the painless gross hematuria with urothelial cancer, but you may find it in both. Now, you know, with this tumor, because of the fact that it is in the urinary bladder itself, not in the pelvis, the patient may actually experience frequency, urgency, and dysuria. So as a result of that, there may be some confusion actually with an ongoing infection, okay? One of the things that you may use actually to get it, because of the fact that it is so close to the exit, you know, the cytology of the urine. Cytology of the urine could be of a great help, really, you know, before you actually go in and scope the patient, you know, and which is more, you know, more invasive kind of testing. So cytology of the tumor, they do what's known as a thin prep, in a very peculiar technique in pathology, where you put it on, you know, on a cytology, you know, slide, and the cells are, you know, evenly dispersed through the slide to make sure that the pathologist or the cytologist will appreciate, you know, all the features of individual cells and structures such as papilla, where you may actually see some fragments of papilla on cytology, you know, smaller fragments of papilla on cytology, perhaps from a person with urothelial cancers. That's it. Any question? All right, guys. All the best. Where's Muntasar should be here. Let's wait before you go. Hey, wait. MashaAllah, wait, ya Rajal.